Afternoon, everyone. We welcome you to the second exchange meeting. I remind you the context. We are the second Tribune, and due to the pandemics and the virtual mode, we divided it into 5 sessions. The previous session was very rich with the Eugene group from Spain. This one is with the Eugene group. Today we have a luxury session with Eugene, Italy, that we expect you will enjoy a great deal. The speakers are very kind, very generous to share their knowledge. We expect you enjoy the meeting and have a good afternoon. I would introduce you who is with me today, Dr. Andrea Kocia. She is a member of the staff of Cegyr, a specialist in gynecological endocrinology, reproductive medicine, a cryopreservation program, and director of the training educational program of Cegyr. And we will try to moderate this event, speak very little, because we expect you can make advantage of the experience of our speakers. First, Dr. Maria Beatrice Dal Canto. She will discuss a very interesting topic. There will be questions and comments for Beatrice. She will talk about semen donation, a valid strategy to improve ICSI results in advanced stage women. And if we would like to talk about their background, we could spend the whole afternoon talking about that. So I have summarized some important items. She's a biologist, graduated from Pizza. She has a degree in hygiene in Milan, senior embryologist. She's been associate faculty of the Milan University. She's a senior embryologist, director of 4 laboratories associated to the development and starting up of many research projects in animals and humans in cooperation with many universities and private groups. She's interested in vitro maturation of oocytes, collaborated with the development of many laboratories in more than 20 years of experience in the topic. So we will make advantage of her experience. She leads the Reproductive Center of Monza, director of Eugene of Modena, Taranto, Milan. For the audience, you can have all the questions and comments in the Q&A box. And then with Dr. Kocia, at the end of the event, we will try and share. And because we have simultaneous translation at the end of the screen, in the world icon, you can select the language. In this case, the speakers will speak English, so those who prefer can select Spanish. Beatrice, you have the floor. Welcome. Thank you very much. And whenever you like.
Noi abbiamo qualche certificazione ISO come qualche certificazione ISO?
Ops. Can you see my screen? Someone can, okay, thank you. Okay, thank you for the kind invitation. It's really a pleasure to be here to share with you our experience. The item of my talk this afternoon is a focus on a sperm donation approach. In the recent years, advanced maternal and paternal age has become a significant concern as women and men delay starting a new family. In face of social changes leading to maternity delay, advanced maternal age has become one of the major challenges in reproductive medicine practice. Several approaches, including a sort of improving of stimulation protocols, embryo evaluation, oocyte and embryo cryopreservation, has been proposed to overcome this challenge. And all the efforts has been focused on oocyte quality, especially. But unfortunately, significantly less research has been focused on understand the male impact. So the paternal contribution to the reproduction. Advanced paternal age has been associated with an increment of sperm DNA damage, and the sperm DNA damage has linked, of course, with the improvement in miscarriage rate, especially during IVF. So, in addition to the paternal age, also the lifestyles of men can affect the sperm quality and has been associated to a poor results in reproductive techniques. However, alternatives approach aiming the enhancing sperm contribution have not yet been considered as a mean to improve reproductive outcomes. Although sperm donation is a growing practice in reproductive medicine, accounting for up to 1 in 5 of all IVF cycles performed in the world, sperm donation has been predominantly applied in couples with maternal age around 35 years or less. So our question is, sperm donation might improve outcomes in AMA patients? And from this question arrive our hypothesis. In AMA patients, sperm donation provides higher live birth rates than those received in homologous normal sperm cycles. In order to demonstrate this hypothesis, we design a multicentric retrospective study. We designed this study using 2 centers in Italy, Clinica Eugene Modena and Biogenesi in Monza, and 1 center in Spain, Clinica Eugene Barcelona. In our retrospective multicentric study, we analyze all the treatment during the period between 2015 and 2019. In total, we selected 755 ICSI cycles at the first attempt of IVF. 337 were homologous treatment. So ICSI inside a regular couple with the specific selection that the male partner have a condition of normozospermic situation. Then we selected 418 cycles of women undergoing to sperm donation process. So, of course, the donor sperm, the donor sample were normospermic, and the treatment was a second level treatment was an ICSI treatment. Our primary outcome was, of course, the live birth rate. But as a secondary outcomes, we analyzed fertilization rates, implantation rate, clinical pregnancy and delivery rate, and at the end also miscarriage rates. The ICSI outcomes were then compared between sperm donation and homologous as a control group in young women less than 37 years and in advanced maternal age women, means more than 37 years old. Analyzing the data, we decide to investigate also the data using univariate and multivariate logistic analysis in order to assess if sperm donation was associated with live birth independently of potentially interfering variables in non-AMA and AMA patients. The independent variables that we consider were number of metaphase 2 oocytes, number of embryos transferred, the day of embryo transfer, the maternal age, the maternal body mass index, and absence or presence of male partner. And here we can see immediately some numbers about the study. First of all, in this table, you can see the two groups, homologous cycles and sperm donation cycles. 337 cycles, 418. The maternal age was approximately the same. The body mass index also was approximately the same. The paternal age, as expected, is completely different because, of course, in the group that use donor sperms, the donors are really very young men. Regarding the reason of treatment, you can see the cause of infertility more or less well distributed between the two groups. Just pay attention to the presence or not of male factor. In the control group, of course, all the cycles have a condition of normospermic, so zero male factor presence. But on the other hand, in the sperm group, in the sperm donation group, we recorded just a few cases, 97 out of 418, of a sample that even though derived from a donor, the straw that arrived in our hands was not so perfect. So maybe the cutoff of normospermic in some cases were not reached. Another attention is on the absence of male partner, because in the Spanish IVF center in Eugen, Barcelona, they included in the study some patients without partner, the single women, who asked for a sperm donor treatment. So in this situation, probably the cause of infertility is a bit different, because we really don't know if the woman was infertile or not, because she was looking at a child because of was a single woman. In this slide, you can see the maternal age distribution in the two groups. And we can see that in the sperm donation group, there is a bit higher percentage of women, around the 39 and 40 or 41 and 42. But the difference is not statistically significant. In the total, we will see what happened. Regarding the treatment, even though the treatment were performed in 3 different centers, the preparation of the patients is more or less the same. The preparation with antagonists or agonists followed more or less the same distribution. The stimulation with different drugs, the same. And mainly we performed single embryo transfer or double embryo transfer. Just in a few cases, we perform a transfer with the 3 embryos. And in that case, the patient was very old. Mainly, we transferred embryos on day 2 or day 3 at cleavage stage, and only few cases at blastocyst stage. Okay, move on the results directly. Here you can see some differences between the control group and the treatment with the donor group, and also the differences between non-AMA and AMA women. As I told you, the maternal age is just slightly different because of in the sperm donation group, we noted a higher percentage of women more than 39 years. Regarding the paternal age, of course, the homologous group is definitely much older than the sperm donation group. And this different is in the both group, in the young women as well as in the older women. Regarding the number of metaphase 2 collected during the treatment, there is a differences in favor of sperm donation group for especially for the young women. This is due to the percentage of women that were included in the study derived from a Spanish center, because of many women were young single women without any infertility cause. And so in that case, the number of oocytes recovered was a bit higher. Our primary outcome was the live birth rate. And so at the beginning, we got this wonderful surprise. Of course, the live birth rate in sperm donation group was significantly higher than the live birth that we could obtain in homologous treatment with the normospermic partner. The difference between the success rate is significant, and the significance is maintained in young women as well as in old women. You can see the difference between 37 and 50% of delivery rate in very young women, but it's even more interesting to note the difference in live birth rate in old women using donor sperm. In other words, if the patient is more than 37 years using donor sperm, the delivery rate is quite higher than what happened in a regular couple with a normospermic situation. Looking at the secondary outcomes, what we can see is that a strange situation happened in fertilization rate. In total, the fertilization rate using sperm donor was a bit lower than in homologous treatment. But even though the difference is very small, is significant, this situation is present also in the U group of non-AMA patients and disappear in the group of AMA patients. Our hypothesis is that these strange results is due to the fact that in a homologous treatment we use normospermic sample fresh. So during the treatment, the partner collects the sperm and we use immediately. In the treatment with sperm donation, of course, the donor sperm is frozen, and maybe the cryopreservation protocol can impact and can manifest its role when we analyze the fertilization rates. Regarding the implantation rates, there is a very small difference in favor of a sperm donation group, but the statistic analysis reveal that we don't have any significance different between the homologous and the sperm donation. We noted a difference between young patients and old patients. In fact, the difference is significant. But inside the non-AMA patients is a trend in favor of a higher implantation rates in sperm donation is not significant. Looking at AMA patients, we noted that the difference is a bit higher. We noted a P 0.075. So there is a tendency that it's really interesting to analyze in future and to see if with a bigger sample analysis we can have a different results. Noting regarding the clinical pregnancy rate, even though there is a sort of benefit, a sort of a trend in favor of using donor sperm in all the categories. And then when we analyze the abortion rates, the significant difference is arrive again under our eyes. The abortion rate reached 23% in regular homologous treatment with normospermic sample, but fall down at 13% when we use a sperm donor. Looking at the very young patients, we noted a benefit also in this group, even though not significant, but it's amazing the benefit in AMA patients. If one woman, 40 years old, who decide to go with donor sperm sample can obtain a really big reduction in terms of abortion rate. And of course, specularly, a big benefit in terms of delivery rates. The delivery rates move on from 13% to 22%, just changing the normospermic sample from the partner that maybe is in advanced paternal age and the donor that is a young and healthy donor. Looking at our univariate logistical regression, here I reported all the data all together. In non-AMA patients, none of the independent variables included in the model were significantly associated with the likelihood of live birth. We noted a tendency in the sperm origin, but is not significant yet. In AMA patients, the sperm donation, the number of metaphase 2 oocytes collected, the number of embryos transferred, the maternal age, were all significantly associated with the live birth. So we are used to consider for AMA patients, very important, the ovarian reserve in terms of metaphase 2 oocytes, the maternal age, but it's important now to open our mind and to also to look also to the sperm origin and to the quality of the sperm. In the multivariate logistic regression, again, in the analysis, we can see that the sperm origin is associated with live birth, independently of all other variables tested. The situation that you can see here appear just in women over 36 years, not in non-AMA patients. So, after this investigation, our conclusion are that the sperm donation is potentially associated with the live birth in AMA patients, but not in non-AMA patients. The reason why sperm donation increase the likelihood of live birth are likely related to higher sperm quality due to the lower paternal age of donors and exclusion of undesirable health and lifestyle condition during the donor recruitment. Greater DNA integrity and a higher availability of paternal factor capable of enhancing DNA repair capacity in the zygote may have contributed to mitigate embryonic and placental genetic defects in AMA patients, compensating the aged X. At the end, the cost effectiveness of a sperm donation in relation to other strategies to treat age-related infertility needs to be evaluated, considering a different clinical and couple profile. Before I send a 42, 43 years old woman to egg donation program, why not consider a sperm donation program? This is the challenge for the future. We are continuous to study this item, and as soon as we will have more information and more data, we will share with you for sure. Thank you so much for the attention.
Muchas gracias.
Thank you very much.
Muchas gracias, Beatrice.
Thank you very much, Beatrice.
Dejamos las preguntas
And
para
now we
después.
leave the questions for the end.
Excelente la
It's
presentación.
been an excellent presentation.
Y tenemos acá en la
And
cabeza algunos
we have
ruidos
here
que
some noise
seguramente
in
después
our
vamos
mind
a
that we will
compartir
probably share later
en el espacio de preguntas. Así que
during the
muchas
question and
gracias.
answer session. Thank you.
Bueno, ahora le damos la
And
bienvenida
now we welcome
y agradecemos mucho al
and
doctor José
thank
Buratini.
Dr. José Buratini.
Quizás en algo se complementen
Perhaps
ustedes dos después
you
al
both
final en la
complement each
discusión,
other in the discussion,
porque es muy interesante el
because it's
tema
very interesting
al cual se va a referir
the
José,
topic José will discuss,
que es FSH y
that is
antimülleriana en el pronóstico de la
FSH
reproducción
and
asistida, los
AMH
mecanismos más allá de
in
los
reproductive
marcadores
assistance,
hormonales.
assisted reproduction
Les voy a
mechanisms
contar
behind
algunas
hormonal
líneas
markers. I will tell you some
sobre el currículum
lines,
de José,
some
también muy
items from
extenso.
José's background,
José es
also
médico
very extensive.
veterinario,
He's a
recibido en la
veterinary
Universidad de San
physician,
Pablo,
graduated from San Paulo
tiene una maestría
University,
en reproducción
has
animal
a
en San
master in
Pablo,
animal reproduction in
hizo
San
su
Paulo.
fellow postdoc
He
en el
took his
Departamento de
postdoc fellow in the
Farmacología
Department
del
of
Instituto de
Pharmacology
Biociencia de San
of the
Pablo
Bioscience Institute in
sobre
San
el factor de
Paulo
crecimiento
on
fibroblástico en la regulación de
fibroblastic growth
foliculogénesis.
factor in folliculogenesis.
Aprovechó su año sabático no para
He took his
descansar,
sabbatical year
sino para
not to
trabajar en la
rest,
Universidad de
but to work
Nottingham,
at
realizando
the
estudios sobre
Nottingham
cultivos
University,
celulares y
studying
factores
on
de
cell
crecimiento de
culture and
foliculogénesis,
growth factors of
afiliado a
folliculogenesis,
sociedades como R,
affiliate to
ASRM, la Sociedad de Reproducción y Fertilidad,
RAAM,
Sociedad para el
Society,
Estudio de la
the Reproduction and
Reproducción,
Fertility
Sociedad
Society,
Internacional de Tecnología
International
Embrionaria y
Society
Sociedad
for Embryo
Brasileña para el
Technology and
Estudio de
Brazilian Society
Tecnología
for the
Embrional.
Study of Embryo Technology.
Ha ayudado en la
He
supervisión no
has
solo de
helped in the
estudiantes de grado, sino
supervision of
también en maestrías y
undergraduate
postdoc, en
students and masters
capacitación y
and
realización de
postdoc
investigaciones.
training and research.
Es coinventor de la patente de Follicular
He is
System for In
co-inventor
Vitro
of
Site Maturation and the
Logistical
Kit,
Assistant patent,
editor asociado a revistas
associate
prestigiosas de la
editor to
especialidad,
prestigious journals,
actualmente coordinador
in the
científico
specialty
de Eugene,
scientific
Italia y
coordinator of
profesor
Eugene, Italy,
asociado
and
de la
associate
Universidad del Estado
professor
de
of the
San Pablo.
University of the State of San Paulo.
Así que una vez más nos
So
vamos a
once
abusar de la
again,
generosidad de nuestros
we will
disertantes.
make
Le
use of their
agradecemos a José
generosity, and we thank Jose.
y cuando gustes,
And whenever you
empezamos.
like, you have the floor. You are muted, Dr. Buratini. Please activate your microphone.
Tiene el micrófono muteado.
Okay, I found it. So thank you. I'll need to change here my.
You're muted again.
I can't find the language button. Anyway.
In the bottom right in your screen, there is a world. You will see a world, and there you can select the language.
If you're listening to me, that's fine. Let's carry on. Otherwise, we're going to get late. So thank you so much for the invitation. And this is an honor.
Ponga la pantalla completa, doctor. Por favor.
Dr. Buratini, if you can find the language session, you can select English.
First of all, it's a technical problem. I would like to thank again Sergio and for this very kind invitation. And it's a pleasure. I hope we can do something together to share our team. Very, very nice. So I'm going to talk about FSH and AMH in assisted reproductive technology prognosis, in a little bit of the mechanisms behind the hormonal markers. So the plan of this talk includes, first of all, a little bit of the context. As you know, we've been using basal FSH and AMH as fertility markers for many years. But then we're going to explore a little bit the biology behind their predictive power and also behind their weaknesses, because as you know, they're not perfect. Then I'm going to...
Perdón, el doctor no está en pantalla completa la presentación.
Also AMH, yes? There's another voice.
Dr. Buratini, Dr. Buratini.
Ponga la pantalla completa, doctor. Estamos viendo la barra. Sí.
Dr. Buratini, if you can see, if you can see the world, if you can see the world where you can see interpretation, and then you find.
Claro. We need you to put the big screen.
Full screen.
And select
both
the English
things.
channel.
If you can select the English channel so that you can speak in the English channel.
At the bottom of the screen, you will
I
find...
have to stop sharing perhaps, and then...
Try again. Do you want?
Yes, I'll do that.
Yes.
Yes.
Try again.
Yeah, okay. Am I still sharing?
No.
Sí.
No, ahora no. No.
No? Okay, so I'm going to start sharing again.
Okay.
Right.
Okay.
So I'm very sorry for this technological problem.
And now we have to choose the full screen.
Completa.
Claro, full screen.
Perfect.
Okay, that's fine.
We're fine now?
Yes.
Okay. So apologies again. I hope that you could follow me up to this point. We were discussing the seminar plan, and we're going to discuss a little bit of the context of the use of FSH and AMH as fertility markers, and then the biology behind, also the predictive power, the predictive, let's say, usefulness, but also behind their weaknesses, because we know that they're not entirely perfect as predictive tools. And then discuss perhaps mechanisms linking FSH and AMH biology with oocyte developmental competence, specifically in the context of maternal aging. So I think you all know, we are all used to this idea, to this concept that FSH levels, basal levels, increase as a woman ages. And this increase is invertedly, negatively correlated with fertility. Also, if we consider a large population of patients, regardless their age, we're going to find a negative correlation between fertility, here represented by delivery rate, and FSH basal levels. So because of that, FSH basal levels, they have been utilized since the early 90s as a predictive indicator of fertility and outcomes success in IVF and ICSI. But soon after it was started to be utilized, quite a few studies, and I'm here representing just a few of them, started to question the predictive power of FSH, mainly because maternal age was appearing as a much more powerful influence. So depending on the age profile of the population, FSH was not that informative, and also taking into the consideration the FSH cutoff levels that sometimes vary a lot between studies. So at the end, after a few years, the efficacy of FSH as a good fertility marker was questioned. And this coincided with the appearance, with the utilization of AMH as an alternative fertility marker. And of course, you all know that AMH has been considered the more efficient fertility marker at this point. Although we need to reinforce, to consider that there's a lot of evidence showing that even AMH is not an ideal fertility marker, considering live birth chance. So these two recent papers, they compared FSH and AMH as fertility predictors. And in fact, immediately after AMH was started to be utilized as a fertility marker, it was natural, was of course automatic, this comparison between AMH and FSH. And as I said, as I mentioned before, AMH has been considered the more efficient one. These two studies, they focus on an interesting aspect to reinforce the superiority of AMH. They analyzed patients showing different profiles of AMH and AMH. In the cohort A, we have patients presenting here a normal FSH, let's say favorable, a favorable FSH value that would be less or smaller than 10 milliunits per milliliter, and also a favorable AMH level that would be greater than 1 nanogram per ml. So these patients, of course, with a favorable AMH and a favorable FSH, they show higher live birth rates as expected. And then when we change the profiles, we have decreases in live birth rates. Here we have patients with a favorable AMH, but an unfavorable FSH level. In other words, AMH higher than 1, but FSH higher than 10. So they do not perform as well as the concordant favorable group. Here we have patients with a normal FSH, but a low AMH. So they have a favorable FSH, but an unfavorable AMH. So they perform worse than this group. And here, of course, the worst in theory group, that is the group concentrating low AMH values and high FSH values. What is interesting here is to compare the patients with discordant values, because most patients, they present concordant FSH and AMH. So you would expect in a patient with a low AMH, you would expect a high FSH. And the other way, if a patient has a high AMH, you would expect a low FSH. But around 25, depending on the population, depending on the study, between 25 and 40% of the patients, they present discordant values. And these discordant patients are interesting because then we can compare when you have discordant values with a positive AMH and discordant values with a positive FSH. So when you have discordance, AMH seems to be more important. So this reinforces that idea that AMH is a better better predictor of fertility and IVF success. That data, I have to confess, never convinced me very much because I had already the biology behind, and I'm going to mention and to explore the biology a little later on. Also considering in the literature that there was some evidence, some indication that maternal age could interfere in the predictive values of AMH and FSH. When I got here in Italy, I talked to Beatrice and we decided to look at our own data and to look at the effect of maternal age in the association of FSH with pregnancy rates. And as you can see here, of course, we have a tendency here that it's not only a tendency, it's statistically significant, but when we increase FSH levels, of course, we get a reduction in clinical pregnancy rate. This is for the total population. Then, if we get very young patients here, we have a much more obvious difference because we go from 36, 37% down to 20% if we move from FSH lower than 70.5 to FSH higher than 10. And we seem to lose this correlation, this inverted correlation as we move towards older ages. So that was our first indication. And after this first indication, we decided to run a more serious study that has just been published in Reproductive Biomedicine Online. So first of all, we did exactly that same approach, considering patients divided in patients presenting concording favorable AMH and FSH variables, patients presenting discording values with a positive, with a favorable AMH or with a favorable FSH, and patients presenting both unfavorable values. The only difference is that we did that in different age categories. So this is our situation for young patients, patients that we consider pre-advanced maternal age that are younger than 35 years. And here we have three groups representing, progressively representing advanced maternal age patients. So if you allow me, let's go first to the right side of this graph and say that it's more or less reflects what we had seen before, the data that those two large studies published before. In other words, this is the total group of patients. So when I have, when the patient presents a concordant FSH and FSH levels, they perform very well. And if they have a positive AMH value, they perform as well as having both positive values. In fact, in this group here, having both values favorable numerically does not improve in relation to presenting only AMH favorable. Here we have a favorable AMH and an unfavorable FSH. So in other words, I can also say that in advanced maternal age patients, the FSH value, having a favorable FSH value, doesn't seem to mean anything, doesn't count. In the other hand, if you go back to the pre-AMA patients, those presenting both values favorable, of course, perform well. But those presenting a favorable FSH and an unfavorable AMH, so AMH here is low, but FSH is also low, so we have a favorable FSH. These patients, they perform just as well, just as good. But if you have a high FSH, regardless your AMH value, regardless your AMH is high or low, you will have a low delivery rate. So it tells us that in young patients, FSH is much a better predictor than AMH. But this is not enough. I would agree that this is a bit iffy. That's a bit nebulous. So let's go for our main approach. We did a multivariate logistic regression. So testing whether FSH and AMH levels, whether they were associated with live birth in different age categories. So as you can see here, in pre-advanced maternal age patients, in young patients, FSH is significantly associated. Having an FSH lower than 10 is significantly associated with live birth achievement, independently of all other variables that we included in the model. And we included AMH, number of oocytes, number of embryos transferred, day of embryo transfer, presence of a male factor infertility cause, maternal age within that maternal group, within that age group, and maternal body mass index. So in this group, only FSH and male factor were significantly and independently associated with live birth achievement. On the other hand, if you look at all the other age groups, and we have quite a robust number, each group here contains around between 480 and 500 patients. Here we have no association at all with live birth achievement, neither for FSH nor for AMH. So the only variables here that come up associated with live birth achievement is number of embryo transfers, number of embryos transferred, day of embryo transfer, and maternal age for the oldest age group. So this is somehow surprising because we would expect AMH to be associated with live birth achievement, at least in older patients, considering the data that I've just shown you. Why AMH does not come out significant in this piece of data? Well, simply because this is a multivariate analysis, and AMH reflects oocyte numbers, oocyte yield. And in the same analysis, we have number of oocytes. So if we have two variables that are not independently associated, none of them come out significant in our model. So this is why in this model, AMH is not independently associated with live birth achievement. But again, I reinforce that in pre-advanced maternal age patients, FSH was significantly and independently associated with live birth achievement. What is also interesting to consider is that in parallel to a significant and independent association between FSH levels and live birth achievement, in younger patients, number of oocytes was not significantly associated with live birth achievement. Also, when we get in our young population, just the young population, here in this row, we have the young population. If we compare young patients presenting discordant AMH and FSH levels, those patients presenting a favorable FSH level, so DFF is discordant with a favorable FSH level, with a favorable FSH value. So these patients with a favorable FSH, they have a better live birth rate compared to patients with a discrepant situation in which AMH is favorable, but FSH is unfavorable. So this is favorable FSH, in other words, low FSH, high AMH. Here is low FSH, high AMH. So in younger patients, again, it's better to have a low FSH than having a high AMH. And this is also interesting because although these patients, they present a better live birth rate, they yield less oocytes, less follicle and less oocytes. So on average here, we got 6.3 oocytes from these patients. And on the other hand, in young patients with a favorable AMH, AMH is still a very good indicator of oocyte yield. So oocyte yield was in fact larger, but regardless or independently of a higher oocyte yield, we have a better live birth rate, a better chance to achieve a live birth in these patients with a low FSH. So this tells us that perhaps FSH is associated, a low FSH value is associated with oocyte quality instead of oocyte numbers. An interesting question that came up to our minds is why FSH doesn't work well then for AMA patients, for patients with an advanced maternal age. Well, our hypothesis, and I think the literature provides robust evidence for that, is that FSH is not reliable in advanced maternal age patients because it becomes too variable. The literature indicates that intercycle FSH variability increases with age. So if you sample a patient on day 2 of the menstrual cycle, this cycle, and it's an advanced maternal age patient, it's very likely that in the next cycle, she's going to show a different FSH value. There's only about between 20 and 40% of repeatability. So this is why we believe FSH levels are not so reliable in AMA patients. It's not that FSH is not associated with mechanisms potentially affecting oocyte quality, but due to FSH intercycle variability, FSH is no longer a reliable reference. And we hypothesize that this is this intercycle variability increases because it's been described by Angela Barwald's group from Canada, and she did very nice work on follicle dynamics in women and endocrine profiles during the menstrual cycle. She shows very clearly that luteal phase dominant follicle and last follicles that start growing in the previous luteal phase, and they crosses and also enters into the next menstrual cycle, they become more frequent as maternal age advances. And here you can see that, in fact, when you have an atypical luteal phase dominant follicle, you tend to have a decrease in FSH levels. Exactly, this is more or less day 2 of the follicular phase, exactly when we take a blood sample to measure basal FSH levels. So this is very likely why FSH basal levels, they are unreliable and very variable in advanced maternal age. So Beatrice has already presented this picture, and just to remember ourselves that advanced maternal age is the main problem in reproductive medicine, or the main challenge, let's say. And much has been proposed to, let's say, deal with this problem. Controlled ovarian stimulation, specific protocols, embryo selection, also, of course, focusing embryo and oocyte quality, but not really solving the problem, because to solve this problem, we should be able to improve oocyte quality in the donor instead of course, we can, and I think it's fair to propose oval donation or sperm donation. It's fair, and I think we must do that. But for me, solving this problem, really solving it, I'm not sure if we can do that, if we're capable to do that, if nature allows us to do that. But solving this problem for me is to make a good oocyte in an advanced maternal age patient. And if we have some change, any chance to do that, we need to understand better oocyte biology. We have to couple basic information with clinical and endocrine information, and then to learn a little better how we can interfere in the system to increase oocyte quality. In this regard, FSH and AMH, they might play different and opposite roles, but in the same context. And I'm going to explore a little bit this idea, starting with this slide that shows a very nice study published recently, where intrafollicular AMH and FSH levels were assessed in relation to the ability to achieve a live birth. So that's the environment that we need to focus on, the follicle. So what does it mean, AMH in the serum? Does it reflect AMH in the follicle? Not necessarily. This study shows that follicular fluid AMH is only moderately correlated with serum AMH. And this is very likely why AMH has been proposed as a marker of oocyte quality, but not convincingly. There's still doubts about it. However, in this study here, follicular fluid AMH concentrations, as well as FSH intrafollicular concentrations, they were highly associated with live birth achievement. So FSH and AMH within the follicle, close to the oocyte, they make a difference. And it's interesting to remember, or I'm not sure if you have already got to know that AMH is a modulator of FSH activity. AMH decreases the expression of the FSH receptor, and also within the granulosa cells, it decreases the production of cyclic AMP, accumulation of cyclic AMP. That is the major intracellular second messenger triggered from FSH signaling. So AMH is a modulator of FSH activity. So that's quite important, because our clinical data would suggest that FSH could perhaps impair oocyte quality. If we have high FSH associated with low live birth achievement, it means that FSH plays a negative role. AMH, on the other hand, modulates in an inhibitory fashion FSH activity. So AMH would favor oocyte quality by inhibiting FSH activity. So how could then FSH activity impair oocyte quality? There are several hypotheses, and all are very robust. One provided and launched by an Italian colleague, demonstrating that high FSH activity is associated with apoptotic induction. We had the opportunity to contribute in an area, to a group of studies. Not only this study, this study was performed in our laboratory in São Paulo quite a few years ago, but there are other studies demonstrating that FSH anticipates the activation of the ovulatory cascade that could potentially generate an asynchrony between oocyte nuclear maturation and oocyte cytoplasmic maturation. But the most appealing evidence and the most robust evidence linking FSH activity and oocyte quality regards oocyte cumulus communication. Oocyte cumulus communication. These are transzonal processes that deliver into the oocyte small molecules and also RNA coming from the cumulus cells towards the oocyte. And there's been very, very elegant studies performed quite a long time ago already by Dr. David Albertini, showing that FSH activity can decrease the density of these transzonal projections. So these are mutant mice producing more FSH. So they are mutant and they express and produce more FSH. So what happened to transzonal processes? They decrease in mutant mice producing more FSH. The density of these transzonal projections is decreased. And also if you treat mice with FSH agonists, you get a reduction in transzonal processes density. And I don't want to scare you with this slide. I know there's a lot of information, and this is part of a review that we've just submitted, and we hope that we can publish soon, that puts together many aspects that are absolutely crucial for oocyte homeostasis that can be severely compromised if we reduce the communication between cumulus cells and the oocyte through these transzonal processes. So this is a confocal image made here in Italy, in Monza, and this is a real transzonal process. And here I am presenting a scheme, an illustration, just to explore what can happen in the oocyte if we decrease this communication between cumulus cells and the oocyte. Well, let's try to, am I okay with time? Do I still have 5 minutes or so? I cannot listen to, okay. Okay, so I'll go ahead. So transzonal processes. they deliver through gap junctions, they deliver pyruvate, first of all. This is the main molecule, the main source of energy for the oocyte, utilized for everything that the oocyte needs to do. So energy support. Transzonal processes also supply the oocyte with NADPH, which is absolutely necessary for antioxidant stress, to control oxidative stress in the oocyte, because NADPH is absolutely required for recycling of glutathione, and glutathione is absolutely required to control oxidative stress in mitochondria and also in different parts of the spindle. So we all heard before that advanced maternal age and the loss of oocyte quality is associated with increased oxidative stress. But so there is this association, but what causes this increased oxidative stress? We still don't know. And here we have a quite robust hypothesis, because as FSH levels go up, as maternal age increases, the decrease in cumulus oocyte communication would compromise the oocyte resources that are utilized to control oxidative stress. Also, the oxidative stress is absolutely required, the control of oxidative stress is absolutely required to control DNA degradation. So this is another important aspect of derived coming from cumulus oocyte communication. But apart from small molecules, the oocyte also delivers polyadenylated RNA into the oocyte. And these polyadenylated RNA are immediately utilized here in the oocyte and produce proteins right away that are very important to control actin dynamics, and also to control the dynamics of the spindle. I'm not going into details because it can go really complex in terms of basic biology, but I can assure that these RNAs, they are fundamental and they're involved in the control of actin dynamics and spindle dynamics. And how FSH can control transzonal processes? How FSH, because there are previous evidence that FSH causes transzonal projections, retraction, but are there biological mechanisms that could justify that? Yes, there are. These have not been explored in the ovary, in the follicle, but we found information in other cell systems, in other tissues. And in fact, as you can see here, I'm not going into details, FSH signaling can activate intracellular cascades that will control actin retraction, because transzonal projections, they're made of actin. They have actin here. And what causes their retraction is the contraction of the actin molecules. And FSH, through its pathways, in intracellular pathways, control actin contractions. Control also the anchoring between the tip of TZPs and the oocyte through these molecules here named N-cadherin and E-cadherin. So it's just to show you, give you a hint of the mechanisms that are behind FSH excessive activity in the cumulus oocyte complex. And as I said, FSH activity needs to be therefore controlled in the cumulus oocyte complex. In fact, it's very interesting to consider that the oocyte produces factors that decrease the expression of the FSH receptor in cumulus cells. So there are natural breaks, natural protection mechanisms One is AMH, as we discussed before. AMH can inhibit the expression of the FSH receptor in cumulus cells. Another one comes from the oocyte. The oocyte itself produces proteins that are secreted and are capable to decrease the expression of the FSH receptor, to preserve transzonal projections, to preserve their connections, their channels, so the oocytes can still receive the molecules they need from cumulus cells. And in fact, we ran a very interesting experiment in Brazil showing that the oocyte tries to protect its connection with cumulus cells. So we cultured here oocytes that were in cumulus oocyte complexes that were intacted. Here, cumulus oocyte complexes without the oocyte, without the ooplasm. The oocyte content was emptied by using micromanipulation. And here we used oosectomized cumulus oocyte complexes with denuded oocytes. And what we have here we have cumulus cells, and we have denuded oocytes that can produce those oocyte secreted factors, BMP15, GDF9, that can help to decrease the sensitivity, the responsiveness of cumulus cells to FSH. And in fact, here you can see that when you don't have the oocyte, in the absence of the oocyte, and therefore in the absence of oocyte secreted factors, we have an increase in the expression of the FSH receptor. And also the oocyte controls AMH expression in its surroundings, because AMH will also contribute to reduce FSH responsiveness. So I think for me, it's very interesting, the idea that the oocyte is not a passive passenger, but it tries to take care, to modulate, to controls responsiveness to FSH, and therefore a communication with cumulus cells. So I think I spoke already too much. In conclusion, I would just like to remind you that basal FSH appears to be a better prognostic tool for young patients for pre-advanced maternal age, and it very likely reflects oocyte quality under these circumstances. Whereas AMH is a better prognostic tool in advanced maternal age patients, where it reflects oocyte yield. And we all know that oocyte yield is very important in advanced maternal age patients. And we propose that increased or excessive FSH activity may impair oocyte developmental competence by reducing transzonal processes density and the delivery of very important molecules for oocyte homeostasis. And the idea, very interesting to close, that oocyte secreted factors and AMH, they protect cumulus cells from excessive FSH signaling, thus preserving transzonal processes. And where do we go from here? So it would be really nice if we could test, if we could run other studies to really confirm that higher FSH is associated with decreased T-zeta-P density in the human cumulus oocyte complex. And if we can confirm this proof of concept in this proof of concept phase, we then should perhaps start to think about strategies to modulate, to decrease FSH activity in young patients with high FSH, or in patients with advanced maternal age, to increase their fertility and their performance in assisted reproductive technologies. So with this, I apologize again for the technical problems, and I thank you for your attention.
Susana está silenciada.
Perdón. Muchas gracias.
Thank you very much. I was telling Dr. Buratini that we are very grateful for his very interesting presentation. Going back to the sources, we wish to thank you. It's been very interesting. We have a few minutes for questions. So I give the floor to Dr. Kocia so that she present the moderators, introduce the moderators, so we can have an exchange that will be very beneficial. Andrea.
Bueno, buenas tardes y
Good
felicitaciones
afternoon,
por las charlas.
congratulations for the presentations.
Yo voy a presentar a las
I'm
discutidoras.
going to introduce the moderators.
La primera es la licenciada Florencia Nodar.
Florencia Nodar.
Ella es licenciada en Ciencias
She has a
Biológicas.
degree in biology.
Dirige el laboratorio de embriología de
Leads
Cegyr.
the Cegyr Embryology Laboratory.
Es directora ejecutiva
She's an executive director of Novagen, member of the executive committee of ALMER. She's certified as director of laboratory for the American Board of Biogenesis, the Argentine Society, and the Latin American Network of Assisted Reproduction. Our other discussant, Martina Carro. She is a gynecologist, specialist in reproductive medicine, specialist in gynecological endocrinology, a specialist in tocogynecology, a staff doctor of the Cegyr, and member of the executive committee of ALMER of the Buenos Aires, Argentina. Now you have the floor. I will start. Thank you very much to both presenters. The presentations have been excellent. And I want to make some questions to Dr. Beatrice. I really enjoyed your presentation. It's excellent. Thank you very much. I think it's excellent as scientific work that improves the results. We have seen that you have achieved to improve the results when using donated semen, but we know that if the advanced maternal age and we offer ovulation, we improve remarkably the results in terms of euploidy of the embryo, clinical pregnancy rate, and live birth. So my question is, why should we use as a strategy, or in what patients would you use as a strategy the change from donated semen instead of oocyte donation? That is my first question.
Thank you so much for your question. First of all, I wanted to underline that our program was a normal program. So we did ICSI with the sperm donation just in case of severe male factor. The surprise was the high results that we could obtain even in old women. And after these results, we open a discussion internally and we say, what is better for a 42, 43 years old woman? Go directly to egg donation or maybe try a sperm donation? Because the complexity of the treatment is completely different. Also, the cost of the treatment is completely different. Okay. Sometimes you can have a good ovarian reserve, a good FSH, good AMH in a 40 years old woman, but maybe you have a very bad sperm sample or just a dyspermic sample. And the decision to go directly to egg donation or to try a sperm donation is now on the table. The physician can discuss with the couple which is the best approach, because the sperm donation program is in Italy easier and cheaper than egg donation program. Okay. So, of course, has been a surprise for us to say to these kind of women that they can reach 25% of delivery rate in using this approach. And we are now step by step trying to propose this approach to our patients. And we will see in the future the final answer for the patient from a point of view of the patients. So it's of course a provocative question, but keep in mind to consider also male age, and in case of male more than 45 years old, try to consider, even though the man is normospermic, if there is some benefits using different approach, different situation. So it's another tools that the physician can have to propose to infertile couple with advanced maternal age.
Clarísimo.
It's been very clear. Now, apart from the economic factor, which is, it's not a minor issue, that it is more economical. If we put that aside, have you thought of doing PGP to add PGT, where, well, I think we should, we would see the employee and you could equal the results in advanced stage patients who would transfer euploid embryo, we put aside the age factor.
Yes, this is a great suggestion. We didn't approach PGT so far in this kind of treatment. And our hypothesis is that we don't know yet why and how a very healthy sperm can help embryo development, but for sure it can do that. And will be very interesting to analyze by PGT that embryos in order to understand if they can have a different assets. Yeah, we didn't do that so far.
¿Cuál es el
What
valor?
is the cutoff value to decide that it is male factor and move to bank donated semen? What is your cutoff value?
So far, all the couple that went ICSI with the donor sperm were 100% male, severe male factor. So does it mean that azoospermic or no sperm at all, or severe cryptozoospermic? Because our approach is also to do many ICSI with Cegyr, because it's not so easy to accept a donor treatment in Italy for ethical and for social and different
religiosas.
Yeah. So even though you have just a few sperm, it's possible to try an ICSI treatment with own sperm. So our study considered just azoospermic or really severe cryptozoospermic situation. So that couple didn't have any other possibility to try to have a child. So they decide for donor sperm. But at the beginning, the physician pushed the couple versus a double donation, because of low ovarian reserve, aged woman, few oocytes. If you consider we can obtain 25% of delivery rate using an average of 4 oocytes detected. And this is really a good result, in my opinion, in my personal opinion. So instead of to push directly versus a double donation, maybe just a sperm donation is enough. This is a big question that we are trying to study and to investigate in deep.
Perfecto, clarísimo. La última pregunta.
Very clear. Now the last question. Do you always transfer day 2, 3, or because you studied in 2015, or your strategy is always transfer embryo day 2, day 3?
Mainly we transfer at the cleavage stage because we reserve the blastocyst stage just in case of repeated failure in previous attempts or in case of high responder women with a lot of embryos available to select to the blastocyst stage. But in all the women, if you have just 2, 3 embryos, it's very hard to go to blastocyst. And so we prefer to transfer at cleavage stage.
Perfecto, muchísimas gracias. Te cedo la palabra, doctora Martina Carro.
Bueno, sigo yo. Muchas gracias. Las presentaciones fueron increíbles. Tengo una lista de preguntas así para hacerle a José. Voy a tratar de acortarlas. Espera que voy a apagar ahí la traducción. Una chiquitita, cortita, que quería sacarme una duda, era cuando hablaste de este ARN polilobulado que se genera, ¿no? Que esto sintetiza proteínas, y estas proteínas, entre ellas está lactina, y estábamos hablando de, digamos, la importancia de esto tiene que ver con la función en la fertilización. No sé si se entiende la pregunta, pero es decir, puntualmente la función está ahí, o el problema que generaría esta alteración en este ARN tiene que ver con la fertilización de este ovocito.
Can you listen me? Can you listen to me? Yes?
Yes.
Okay. Well, in fact, different aspects can be harmed, can be deregulated if this delivery is interrupted or decreased. Among these, the polyadenylated RNAs that were already identified, and this was done in the bovine model, there are zinc finger proteins that regulate gene expression. So that means that also the maternal resources that are being prepared to sustain embryo development until embryonic activation, that could be impacted. Some specific proteins that regulate actin dynamics, and actin dynamics is fundamental for spindle polarization to carry the spindle closer to the oolemma, and also for interspindle actin dynamics, so to control chromosome movement within the spindle. There's also another piece of evidence, very, very interesting, that shows that these connections and the delivery of this polyadenylated RNA is very important to allow a complete translational reprogramming that takes place in the oocyte between the GV and M2 stages. So there seems to be a complete reorganization in the translational activity in the oocyte when this final, very final moment of nuclear maturation is achieved. So there's a huge revolution in the oocyte. And without these connections, without this RNA, this revolution does not occur successfully. So I hope to have answered, but I can share some of the papers, and they'll all be included in the review that we submitted.
Perfectamente.
Thank you perfectly. And now let's lower this down to the clinics level. I'm a clinician, so I'm not very well versed on the biology side of it, but this information is relevant for us to be able to optimize it to treat my patients. So it's like the revival of FSH. It's like we are giving it a second chance. We thought that AMH was going to save our lives, but FSH has a role to play in young women, we may say. So what is your suggestion, your recommendation, if I was working with you in a lab, based on your experience? What is it that I have to ask for my patients? FSH, AMH, of course, follicle count is far from biologics, but it's also part of our analysis for ovarian reserve. So what is it that I need to request for screening if she's younger than 35 or older than 35? And based on that, well, sometimes we have patients that will go for a fertility oocyte preservation, and they say, well, my fertility is low or my FSH is too high. So we have to base on that to tell them it's not worthwhile to do the cryopreserving or always do it. And maybe we can have that result to counsel our patients.
Very good questions. First of all, regarding the prognostic part of the question, our data, the paper that was published in Reproductive Biomedicine Online shows that for patients under 30 years, FSH is more powerful as a predictor as in relation to AMH. And for these patients, what counts is oocyte quality. So there are, of course, there's a smaller variation in terms of oocyte yield, and what seems to determine the success, live birth achievement, is oocyte quality. And why FSH works for these patients? Because for young patients, there's no FSH intercycle variability. Those phenomena regarding late lutein phase dominant follicles, the peaks, surges of estradiol in the middle of the menstrual cycle that occurs there are often in advanced maternal age patients, but we do not see those in younger patients. So that's why, because there's no intercycle variability, so FSH is reliable. That is important because it doesn't mean that FSH cannot be a biologically negative factor in advanced maternal age. Simply the clinical association is gone because of intercycle variability. I think that's my hypothesis, that's my point of view, because the biology is only one. But in terms of prognostic, of a prognostic approach, unfortunately for older patients, AMH is more efficient, and it reflects in that case oocytes availability, numbers of oocytes. There's a very nice, interesting study that shows that oocyte number, of course, is important, is associated with live birth achievement. But what we do when we have an advanced age patient with a small follicle cohort, we try to push a little bit with FSH, right? To avoid spending a lot of time, and then we're going to There's a very nice recent study showing that advanced maternal age follicles, they do not have less receptors or a smaller capacity to respond to FSH. So there's no point in increasing FSH too much, because it's not a matter of lack of responsiveness. It's simply lack of follicles. And if you increase too much FSH, you're going perhaps to harm those follicles that are still there. So it's natural, but we're starting to understand this now. In fact, it's also interesting because if these follicles from advanced maternal age patients, from poor responders, otherwise they seem to lose the down response, the down regulation mechanism, and end up having also an increased capacity to respond to FSH. So the damage from FSH could be also enhanced in these patients. Having said that, I'm not against FSH. FSH is very, very important. It's important to recruit follicles, to start a wave, but it has to be well utilized. It has to be well utilized. I hope to have answered well.
Excelente. Excelente. Muchísimas gracias. Tengo varias.
Excellent, excellent. Thank you very much. I have several questions. I've seen that there are a lot of questions in the chat box. Maybe we can read those, or you tell me.
I'm available as you. I have no time.
Maybe we can read some questions from the audience, which are related to what Dr. Carro has said. I will start with the last questions, but a recurrent question is whether there is a hypothesis or some future treatment to apply in patients to reduce these high levels of FSH.
Yeah, this is also a very good question. Because I think that, well, one would immediately think of steroids, and I'm not sure if we can, in a robust and sustainable way, to control FSH levels with steroids. We need to try. Steroids would be one possibility. We still don't have other tools. There's a very promising alternative that is recombinant AMH. There are studies in rodents using AMH, and it's been proposed for also as a future treatment for cancer patients to suppress follicle activation and preserve fertility for a longer term. So it's been shown in mice that you can decrease FSH activity without compromising follicle quality and oocyte quality using recombinant AMH. So recombinant AMH, instead of suppressing FSH, regulating FSH responsiveness with AMH, and that's why intrafollicular AMH is a very efficient marker. The intrafollicular, of course, we don't measure intrafollicular, we measure serum AMH. But if we could do intrafollicular, that would be perfect, because that would reflect the ability of that follicle to control, to modulate FSH activity. So yes, we need to think about GnRH antagonists, steroids. We have to try. We have to try. I wouldn't remove FSH activity at all. I would just try to bring it to healthy levels. I'm not against FSH. People may think that I hate FSH. No, that's not. FSH is very important, but at the right level, at the right time.
Bueno, creo que ha sido excelente.
Well, I think that this has been outstanding. We have a lot of questions, and we have tried to include all of the questions because they are quite similar with the questions asked before. We could go on and on with this conversation, but unfortunately, we do not have enough time. We thank you all very much for being with us this afternoon. Dr. Dal Canto, Dr. Burattini, Dr. Carro, Dr. Nodar, also Gustavo, the technical staff, the labs and industry, because we wouldn't be here without them. And of course, all of you participants and audience sharing a scientific afternoon in Argentina. We thank you all very much. And I remind you, our next date, our third session will be on September 9th with the Boston group. And then we'll have on November 11th with the Brazilian group, and on December 2nd with the Stockholm group. So thank you all very much. It has been wonderful. It's been a pleasure. We thank you all very much for sharing your knowledge with us and spending a nice afternoon. Thank you very much. Thank you, Maria Beatrice and Jose. Thank you very much.
It's been
Take
a
care.
great pleasure. Thank you.
Gracias a todos.